patients with ocular surface disease. These are line disclosures. And your dry eye disease is obviously one of the main forms of ocular surface disease. It affects around 1 in 3 chronic progressive and detrimental quality of life. So it's vital that we are doing something about this for our patients. MGD is introduced to logical drivers. We know over the last year lid disease, as mentioned in the lid margin disease, as is mentioned in T-cross use.
E poi lo metti su un link, questo come lo fai? E me lo mandi il link, ma io non guardo le foto. Non è
with microbial dysfunction, you get that loss of the lipid, and that lipid drives a self-perpetuating cycle of inflammation, instability, fibrosis, ocular surface damage, inflammation. And so what can we do about it? Well, we can actually use patient lid warming therapies, washcloths, which we prove don't work. The remainder of them, as long as they get to around 40 degrees in temperature,
non ci ho mai guardato.
if they are dry, they are actually effective. However, we know that the problem is patient compliance, patients just cannot
Perché
comply
qualche
with that.
cazzata di mesi l'ho detta, però non sto abbastanza
treatment. And so it's really good when we see the number of in-office therapies that we have available to us now.
preparata.
Thermopulsation came out first when we was the
Io
flow, which allowed 12-minute biological treatment for patients. Typically, hours from the inside, when it warms temperature, it progresses to expel the light from the glands. And the sustained high-lux is similar in concept. It keeps from the inside. Pressure from the blood and the outside is activated, so you can have a bit more control. But basically, that's the same as our warm compress, except that it's inner or the warming rather than outer, followed by gland expression. So similar kind of concept. And it wasn't really until just over a decade ago that we started really seeing the light-based therapies becoming available to us in clinical practice. So I was lucky to be involved in some of the first studies on intense pulse light that we now know we're very familiar with as being successful effective treatment for dry eye disease. And since that time, there's been a huge increase in the number of publications. But it's not going to be for everybody, and it may not be enough in itself. And it has a bunch of indications, primarily skin type. You can't do the darkest skin to black PL because of the risks associated with the increased heat absorption with it, and pregnancy, for example. And so when we go to T-cross GS3 and look at the eyelid algorithm and look at the different treatment options that we have available for microbial dysfunction as one of the etiological drivers, we can see that there are an increased number of options, and within that we've got low-level light therapy, as the yellow light preserved 5 to 90 nanometers, also has an anti-inflammatory effect and is efficacious in reducing edema, and so it has indications post-surgically, particularly in after capacity. So as I finish off, I thought I would just talk about some of the publications that are out there, particularly because this session is about surgery and preparing surgical, that kind of arena and what we can be doing. And so the low level light therapy has been used in that setting. Again, some really good local work showed a new protocol that suggested doing applying low level light therapy 7 days before cataract surgery and then again 7 days after surgery. And that was trialled in a high quality randomized controlled trial versus a sham treatment, which didn't give the right amount of light. And it was assessed and it was shown that by doing that we could ameliorate the tear film stability issues and discover symptoms that were associated with cataract surgery. So the implication is that it should be easy enough to add something like that kind of treatment into the work assessing when you're dealing with patients who are applying for routine cataract operation as a prophylactic to try and mitigate some of these symptoms that patients often suffer from. This is another similar trial, similar idea, using this protocol conducted in Romania around one of my collaborators in another study, using 50 patients, 50 participants who were treated with low level light therapy for each and showed significant benefits in the OSDI and tear time in patients without cataract surgery. So it was effective in preventing post-operative increases in tear osmolarity, in symptoms and ocular surface damage. So it didn't necessarily make them better, but in the other eyes, those that didn't have the treatment, they got worse. So it protects against that. And finally, we need to not forget about laser refractive surgery for refractive error correction. So lasing, there's a study that's been done looking at, again, a similar effect of trying to prevent issues from patients who undergo this type of surgery, because it's common, we know that this is a common problem that we have. And it was found that they improved the material system, shirt as the DEQ5 were shown to be better than the LLT. And again, as the LLT stayed stable, the other eyes got worse. And so perioperative low-level light therapy appears to be safe and well tolerated as part of that treatment, as part of that overall treatment for our patients to try to provide support and prevent issues over time. So in summary, dry eye remains common and is debilitating for patients. Iatrogenicity, so when we're causing ourselves, is a significant risk factor. So it's important to try to do what we can prophylactically to prevent that and prevent to post-operative dissatisfaction and suboptimal visual outcomes, especially with all the high-quality lenses and things we're using nowadays. TPOS used viewers can help push you in the right direction to know what there's good evidence for in terms of treatment options, but within that, low-level light therapy offers effective prophylactic option for patients undergoing cataract and refractive surgery. Thank you for your attention.
Molto preparato nell'ambito della tecnologia delle lenti fredde e ci parlerà della storia of eyeliner intelligence with dry eye.
Buongiorno a tutti, grazie dell'invito, grazie Luca, grazie al dottor Tedesco, benvenuti a Napoli. Io vi parlerò ovviamente della scelta della lente presente con un'anima. Ovviamente l'argomento fondamentale, il topic fondamentale del Congresso è appunto le alterazioni del filo animale e fondamentale considerare l'utilità del filo animale ogni volta decidiamo di impiantare lenti adatte alla tecnologia. Questa è un'immagine che più o meno cerca di riprodurre quello che è un effetto generato da un filo animale stabile e normale. Considerando che il 70% dei problemi rifrattivi sono dovuti ad un'alterazione dell'interfaccia tra ave e lacrima, quando noi abbiamo un'alterazione filicatimale abbiamo un'alterazione della funzionalità. E questo esempio ovviamente diventa determinante ogni qualvolta decidiamo di impiantare lenti che richiedono una visione ottimale. sia qualitativamente che quantitativamente performante, cercando ovviamente di andare a eliminare i disturbi post-operatori. Quindi l'importanza del filo capillare significa avere una superficie oculare intera. Altro elemento fondamentale è indispensabile quindi andare a eseguire un'attenta valutazione pre-chirurgica del filo capillare. E a questo punto noi dobbiamo considerare che dopo l'intervento di chirurgia potremo avere una normale alterazione del filo capillare post-chirurgico che avremo comunque ogni volta andiamo a creare un progresso infiammatorio o una funzione patologica. Ovviamente questo è un elemento che è stato abbondantemente discusso, come potete osservare, e tra le cause iatrogene di alterazione della superficie oculare rientra sicuramente anche la vertigine retrograde. Questo è quello che succede quando il nostro sistema lacrimale, risulta essere perfettamente in equilibrio. Quindi noi abbiamo una nostra esterna, un movimento chirurgico, ma il bilanciamento dinamico è in grado di mantenere l'equilibrio, quella che è la nostra della superficie oculare, evitando quindi delle alterazioni significative. Quando invece questo bilanciamento dinamico risulta essere alterato, ci troviamo di fronte a una superficie oculare disfunzionale, quindi con delle serie di problemi. Fino a rimanente cosa significa avere una superficie oculare integra? Che cosa ci consente? Una migliore valutazione preoperatoria e di conseguenza un migliore risultato post-operatorio. Quindi è fondamentale studiare con attenzione con quel paziente prima dell'intervento, cercando di evitare l'impianto di lente della tecnologia in tutti quei casi in cui noi sappiamo di avere un filo capillare. In tutto questo ovviamente svolge un ruolo fondamentale anche l'integrità del plesso nervoso, dove alterazioni di questo tipo vanno ad alterare la struttura epiteliale superficiale. Quando andiamo a scegliere una lente, noi dobbiamo avere una superficie oculare che possa in qualche modo garantire un ottimo risultato. Quindi dipende da quanto accurata sia la valutazione preparatoria e quanto riusciamo a essere precisi nell'analisi biometrica. Quindi un buon filo capillare ci consente di essere precisi nel calcolo della lente e anche dalla scelta di lenti premium. Quindi ci consente di ottenere una stabilità refrattiva senza visioni fluttuanti e di conseguenza una buona soddisfazione del paziente. Ad esempio in questi casi possiamo vedere come la superficie oculare rappresenti un virgine da norma, una superficie regolare. In questi casi sicuramente la scelta di lenti trifocali può essere adeguata a mantenere un'ottima risposta post-operatoria. Per esempio questo è il risultato di un questionario eseguito con l'impianto di lenti trifocali, in questo caso quello delle lenti che utilizzo di più, la Genetic, dove i pazienti adeguatamente selezionati andavano a valutare i risultati post-operatori. Come potete vedere, in queste circostanze l'utilizzo di occhiali risulta essere realmente limitato a poche circostanze tipo guida notturna oppure lettura con scarse dimensioni. Come andiamo a eseguire la diagnostica? Sicuramente ne abbiamo parlato alla grande in queste giornate, ma bisogna, oltre a fare la valutazione strumentale, anche soffermarsi su quelli che possono essere questionari che vanno in qualche modo a indagare sulle attitudini del paziente e sulla sintomatologia che il paziente riferisce. Oltre poi ad andare nel dettaglio a valutare il time, lo studio delle anni del copio, il filo capillare, la presenza eventualmente di alterazioni biomarche come le metalloproteinazi e così via. Questa ad esempio è una superficie oculare alterata. In questo caso ovviamente lo studio mi porta a valutare una condizione non adeguata all'impianto di una lente premium. È fondamentale quindi studiare circostanze come questa, ma in queste circostanze è anche possibile instaurare una terapia e ottimizzare, migliorare la superficie oculare per ottenere risultati di questo tipo. Questo è lo stesso paziente, vedete la regolarizzazione del dischi di placido, una regolarizzazione del profilo topografico. Dopo un'adeguata preparazione questo paziente si è reso poi idoneo all'impianto di lenti premium. È ovvio che bisogna immaginare l'elemento chirurgico come un elemento che va a creare uno squilibrio nell'omeostasi del paziente, per cui quanto più precisa e quanto più è regolare la superficie oculare preparatoria, migliore sarà il risultato post-operatorio. Quali sono le circostanze in cui ci possiamo trovare? Filo capillare normale, ovviamente, dove andiamo a valutare l'osmolarità, il VT, non abbiamo alterazioni di steni significative. In questi casi abbiamo una superficie stabile che ci consente di impiantare lenti adatta tecnologia. Sappiamo che questo paziente avrà un risultato soddisfacente. Andiamo a vedere come in questo caso tutti gli esami ci danno un semaforo verde per impiantare diventare anche lenti di tipo diffrattivo, quindi trifocale, oppure lenti EDOF refrattivo. Possiamo trovarci delle condizioni in cui abbiamo un'alterazione di grado lieve moderato. Troviamo delle piccole alterazioni dello smolaritato, quelle che superano il 300 ma non superano il 320 dello smolaritato, e notiamo una certa instabilità. Rischiamo di avere o una biometria inadeguata di un calcolo preciso, e rischiamo in questi casi di portare il paziente ad un risultato non soddisfacente. In queste circostanze si rende indispensabile trattare il paziente in maniera adeguata prima della procedura chirurgica, quindi utilizzando sostituti renali, steroidi di superficie, per esempio il cortisone, oppure la dopamina, il calore, oppure trattamenti strumentali come il luce pulsato o la frequenza. In questo caso possiamo rivalutare il paziente dopo la terapia. Se siamo in grado di portarlo a una condizione di normalità, possiamo procedere con la scelta di lenti diciamo un po' più performanti, altrimenti sarebbe opportuno scegliere categorie di lenti meno impegnativi. Come possiamo andare a fare il trattamento? Possiamo gestire la causa, quindi andare a risolvere l'infiammazione con una terapia topica oppure terapie strumentali, e andare ovviamente a ridurre l'iperosmolarità associata alle alterazioni di superficie. Oppure possiamo andare a gestire l'effetto, quindi favorire la rivitalizzazione neuronale, utilizzando gel, sostanze rivitalizzanti, o in casi un pochino più avanzati anche il PRP, la membrana atomica o l'elettrodopato. In caso invece di granulare severo, a questo punto il processo diventa un attimo più complesso. Cercare di rimandare la chirurgia può essere la soluzione migliore, anche perché l'evento chirurgico creerà sicuramente un trauma importante, dal quale sarà più difficile e più complesso del futuro. Sicuramente questi pazienti non sono candidati all'impianto di lenti focali oppure lenti refrattive, ma bisogna scegliere lenti a tecnologia più semplice. In questo caso, ad esempio, io utilizzo lenti anche monofocali classici, cioè monofocali avanzate, come ad esempio la Impres, che consente di ottenere una buona indipendenza all'uso degli occhiali senza però richiedere particolari risposte da parte del paziente. In questi casi, per esempio, potete vedere come abbiamo delle alterazioni ideali, soprattutto al centro, che non sono in grado di offrire una regolarità della superficie. Vedete che l'astigmatismo della curvatura tangenziale non mostra un profilo regolare. In questi casi quindi abbiamo avuto una risposta scarsa per risultati modesti. E ovviamente in queste circostanze possiamo avere la cosiddetta sindrome del risposto post-operatorio. Significa che può verificarsi sia nei pazienti normali operati, ma a maggior ragione nei pazienti che presentano di base un'alterazione della superficie oculare. Che cosa si manifesta? Visione non nitida, fluctuazioni della vista, pazienti con piremia, sensazione di corpo estraneo, fotofobia. Questo sicuramente è uno dei elementi più frequenti che si presenta a noi chirurghi che andiamo a eseguire chirurgia del sedimento. In queste circostanze dobbiamo cercare di ottimizzare e interrompere il circolo vizioso, quindi stabilizzare la superficie oculare, cercare di limitare quello che è il danno cellulare, ridurre lo stress ossidativo e ovviamente andare a ridurre l'infiammazione. Ovviamente le conseguenze che dobbiamo andare a modificare sono appunto la terapia globale, che molto spesso si verifica con la congiuntivite filamentosa, ma anche tutti gli eventi associati a un disagio del paziente, quindi distorsioni, sottrazioni della vista e di conseguenza formazione di alterazioni di alto ordine che compromettono poi la qualità della visione. C'è da dire che la trasmissione del segnale luminoso attraverso un epitelio irregolare, attraverso il film lacrimale inadeguato, crea praticamente alterazioni di ordine elevato che vanno non solo a creare fluttuazioni visive, ma vanno a interferire con la tecnologia ovviamente delle lenti ad esempio diffrattive, come quella che vedete qui in basso. Per cui l'MTF c'è la capacità di trasdurre il segnale attraverso i mezzi di ottici, si riduce notevolmente e il paziente riferirà ovviamente la visione non nitida, ma effettivamente scadente, non riuscirà a vedere la lontana, non riuscirà a vedere la vicina. In questi casi sicuramente la scelta di queste lenti risulta essere molto limitata ed è molto più indicato utilizzare lenti che offrono una tecnologia meno impegnativa. In questi casi anche queste lenti possono offrire buoni risultati senza però compromettere l'indipendenza della vita. Quindi in conclusione, che cosa è fondamentale? Valutare in maniera approfondita il filo arrivare della fase preparatoria, escludere dalla chirurgia con il riprende tutti i casi che presentano una varianza vera che non stanno in grado, cioè non si è in grado di ottimizzare. Le lenti con tecnologia rifrattiva sono da preferire nei casi di soggetti che presentano fin da prima integro e ovviamente scegliere lenti con tecnologia più semplice e meno complessa nei casi di gravità estrema. Vi ringrazio per l'attenzione e
They have a lot of experience in neuropathic pain. Since 2022, they have developed a neuropathic pain clinic inside the Singapore Eye Center, and they have published a lot of papers and works on this topic. So, I don't want to bother you with the definition, but we know that symptoms of neuropathic pain are pain, irritation, discomfort, aging, phobia, typical pain without stain or patient. And most of the time, this is a headache for us, right? The ophthalmologist, because we don't understand why the patient has so much pain and we can see anything in the exam. So the etiology, we already have talked about this. We have peripheral cause, where ocular disease, dry eye disease is the most common cause, also post-refractive surgery, post-operative surgery, or post-operative keratitis, and then we have systemic causes like fibromyalgia or general neuralgia. And the management, the typical management of these pathologies, topical agents, eye drops and anti-inflammatory drugs, and of course, if we want to work with systemic agents for central component of this neuropathic chronic pain, we have gabapentin and pregabalin. But what's happened when nothing else works? What are the options in this patient when we can't find good results in treatment? Why electrical therapy, QMR, or Rexonide would be an option? Well, because we know that peripheral nerves electrotherapy has been effective with peripheral nerves, painful diabetic neuropathy and painful peripheral neuropathy. In the eyes, we know that transcutaneous electrical nerve stimulation has been shown to relieve ocular pain in more cases. It's reported. And of course, we know that QMR is an excellent treatment for dry eye. And if dry eye is the most common cause of neuropathic chronic pain, maybe it's an effective treatment for this pathology. So the clinical trial in Singapore is showed that before the eyes from 20 patients, the criteria for this protocol was presence of pain or pain-like symptoms. Abnormal nerve findings with microscopic confocal microscopy, a minimal or absent of stain. The treatment protocol was weekly for 8 weeks, one session per week, over between 4 or 5 or 6, and 20 minutes each. Again, remember that the dry eye protocol is 4 weeks, one session per week. Okay, this is double of sessions for these patients. The overview of assessment, assessment of sensitivity, treatment, clinical time, pain questionnaires, patient experience. We are going to see the result later, and of course, confocal microscopy. In confocal microscopy, the group studied the corneal nerve fiber length, the nerve fiber density, the branch density, the total branch density. Let's go and move forward to the result that is the most important here in this protocol. The patient population was 50% of the patients, they had peripheral pain, the other 50% was a mixed and central type corneal pain. Almost 74% of the patients had chronic dry eyes. see that 30% of the patients, they have depression here, here. The other 40% have migraine headache, and almost 30% of the eyes, they have private refractive surgery. So I think this data is very important. So we have the PDAS, that is a pain score questionnaire. We can see a significant reduce after the treatment with a great reduction after the 4 weeks. Here, right? After 4 weeks, the patient has a significant reduction of the pain on these scores. We have the OPAS, the ocular brain assessment survey. It's not just for know the intensity of the pain. We can here measure the intensity, the quality of life of the patient, the result of the treatment. It's a more complete survey questionnaire, and we can see here the results. Patients have a reduction in the pain that interferes with general activity, with the pain that affects them. They have a reduction of the pain that is increased when exposed to volatile chemicals. They have a reduction of the pain that is accompanied by redness, and a reduction of the pain that interferes with the relation with other people, and with a significant pain relief for all the patients. And we know that if the OPAS pain scores improve, the better quality of the patient improve. These patients, particularly pain patients, this is the first challenge or the main challenge, try to improve the quality of life of our patients. Then we have the patient experience questionnaires, and we found that 71.4% of the patients said that the situation is better now after the treatment, after the proximal treatment. Almost 80% of the patients said that the treatment is pleasant. Another 57% said that the treatment is effective. 71% said that the treatment is durable and that works better on the treatment. And then finally, we have another question, the acceptability and satisfaction scores. And what the patients say, 60% of those patients feel highly comfortable, almost 50% consider convenient if you have to do this once per week. Just remember, 2 months going to the eye center every week for this treatment. Almost 47% will recommend this treatment also with other patients, and also 47% feels quite satisfied with the treatment. If we go to the focal microscopy, it's also a very important result. We can find that the depth and the length of the fibers has improved, and also the total range has improved. You can see all the results here in the bottom of the slide. And also the ocular surface system has improved in cornea sensitivity with a significant improvement after 8 weeks of treatment regimen. So, in summary, for the future, here neuromediator and proteomic analysis are studying and maybe presenting the result of this in the final of this year. We have to expand the cohort of subgroup analysis to understand what patients have better results, the patient with herpes keratitis or post-refractive surgery, and of course, QMR can reduce the dependence of the treatment nowadays. So, take-home messages. Proximite is an effective pain relief in neuropathic pain, improving the quality of life. And again, for us, this is the most important in these special patients. Quantum molecular resonance QMR also improves the corneal fiber density and the length. That's also significant that improves corneal sensitivity. Good acceptability and sensitivity from almost all the patients. Thank you so much for your time.
Che può avere un effetto anche nella terapia del drainare, e questo è stato anche sancito da recenti pubblicazioni sia come la clinical trial, in cui si mostra un aumento, miglioramento della sintomatologia dei pazienti affetti da drainare, ma anche la recente pubblicazione del tifo Studios 3, in cui vengono sottolineate appunto le proprietà mucinosimili della seta antinfiammatorie e gli effetti appunto sulla sintomatologia del drainare. Un altro effetto delle proteine della seta, come per la cute, è sulla biorigenerazione, il processo di biorigenerazione della parola, che è un processo piuttosto complicato, regolato da una sequenza di segnali che non conosciamo nemmeno perfettamente, sequenza di segnali che dicono alle cellule di attivarsi, di proliferare, di migrare, di avere tra loro, di differenziarsi. E questo meccanismo, soprattutto nella cornea, è regolato da alcune proteine, che sono le proteine, le machinasi, alcune famiglie di proteine molto nutrite, come per esempio l'E1 e 2 e espressione appunto del geneggiante, che sono tra le più importanti. Guarda caso, le proteine della seta aumentano la fosforilazione di queste machinasi e anche l'espressione del gene ciliato. Quindi effettivamente in vitro è dimostrato appunto come le proteine della seta aumentino la crescita cellulare, la lesione cellulare e la migrazione cellulare. E infatti studi su modelli umani mostrano come l'applicazione di concentrazioni variabili di proteine della seta accelerano la riparazione e l'internizzazione e la formazione del trangiancino sull'epitelio colminale. Questo è anche spiegabile, perché normalmente la chiusura della ferita epiteliale avviene per movimenti appunto di shift-like dell'epitelio tutto intorno alla perdita di sostanza, che appunto scivola sul fondo della luce epiteliale e poi con movimenti di adesione e di proliferazione riempie la perdita tissutale. Se noi invece abbiamo un substrato fatto di seta, ovviamente questo processo viene accelerato, perché le cellule direttamente possono crescere e proliferare e differenziarsi sulla seta, e quindi accelerare il processo la chiusura delle ferite delle proteine. La moleccellulosa è un polimero con caratteristiche non ortogonali di cui ben conosciamo. Abbiamo imparato a apprezzare le proprietà viscoelastiche, gradanti, lubrificanti e mucoadesive, che sono dimostrate molto simili a quelle dell'acido ialuronico, che noi conosciamo molto di più, e applicato sia nella terapia del drainare sia nella chirurgia oftalmica. Però il tentativo, soprattutto in chirurgia estetica, è di trovare appunto dei polimeri che possano anche resistere ancora maggiormente alla degradazione e quindi di resistere di più per esempio con i filler. Questo è applicato anche all'occhio, infatti crosslinkando la nostra moleccellulosa riusciamo a renderla più resistente per esempio all'azione degradante degli enzimi, magari in presenza di infiammazione, in presenza di un processo litico, e quindi aumentare le loro capacità appunto microscopica, mucoadesiva e anche la persistenza, e quindi migliorare una molecola crosslinkata sicuramente persiste di più, meglio di una limitata. Questa è un'esperienza appunto dell'associazione tra la prossima cellulosa crosslinkata associata alle proteine della seta in pazienti appunto sottoposti a una chirurgia con sensibilizzazione, quindi una chirurgia refrattiva, ma anche per esempio un crosslinking, in cui questi pazienti mostravano già un'epitizzazione a 24-48 ore con uno spessore corneale già di a 48 ore di oltre 70 micron. Questo è lo storytelling dei pazienti e le mappe appunto epiteliali, tomografiche. Alcuni esempi, vedete, per esempio il crosslinking, quando facciamo il crosslinking rimuovendo l'epitelio, una delle paure, soprattutto se trattiamo bambini, è quella che viene subito prima per evitare i problemi che vi rischi che non conosciamo, nei 2 giorni e poi si completa completamente, così come in una procedura refrattiva di superficie a 3 giorni abbiamo un risultato che già ci soddisfa e ci mette tranquilli. Però l'evoluzione è anche in altro. Mentre faccio trapianti, il problema principale attualmente serissimo è vedere dei tessuti subitori che tessuto che sopravviva all'undovermine, e qui ovviamente ci sta pensando all'ingegneria, perché la proteina stessa possono anche essere un ottimo scaffold dove fa crescere i fibroblasti differenziali, fa produrre uno stroma umano, ovviamente sintetico, che speriamo un giorno possa anche aiutare a costituire una cornea artificiale per risolvere questi problemi. Ci sono già delle esperienze in letteratura e vedremo il futuro. Io ho finito, vi ringrazio.
Il contributo di Luca, che è anche di una visione presentato, e ci parlerà di questa cosa, che è improving ocular surface, optimizing the near field appearance.
Grazie, thank you very much. Thank you all of you for attending the meeting. And yes, now I'm talking about another issue, another important issue, that is the clearance of the TRP. Because if we want to get a very important, very healthy ocular surface, I think that we have to improve the production of TRP and the quality of the TRP, but also we have to take care also of the clearance of the TRP. And this is because we don't want the concept of this closed circle, this vicious circle that is common in all kinds of dry eye disease, like the laboratory dry eye disease, the phenomenal dysfunction, we heard a lot about it, or the hyposecondary dry eye, the real dry eye, and also the mixed dry eye disease. This is a combination of the first two. And so, what do we get if we have a patient with evaporative, what we can find in a patient with evaporative dry eye disease and phenomenal dysfunction? We find that this patient has a poor or bad quality of TRP because of the poor quality of meibomian production. We, in some cases, we have an excessive evaporation because we have a low layer, but we have sometimes an excessive tearing, and so the patient may complain because for an excessive tearing, not a poor tearing. And in these cases, but also in case of excessive tearing, the cornea is not protected in a proper way. And sometimes also in the tear film we have toxic substances that may be the cause of this excessive tearing, because change the cornea sensitivity. In case of hyposecondary dry eye, we have a poor aqueous production because we have the lacrimal deficiency. In this case, we have as well a fast evaporation, but the tear film may also a good quality of tear film, because in this case, neighbor production may be good, and we have only a poor aqueous production. But even in this case, we have an effective corneal protection. And in this dry eye, having the combination of both the previous two, sometimes the patient complains a lot and has a mix of features and symptoms of the first two kinds of dry eye. There is another issue that is the correlation between dry eye and ocular surgery. We heard about it in all kinds of surgeries, ophthalmic surgeries, but especially the anterior segment surgery may cause this kind of dry eye because of the damage of the nervous plexus, epithelial nervous plexus, and damaging with a incision, with a flap, with a tunnel inside the cornea, damaging the nervous plexus, we may induce ocular surface inflammation, and ocular surface inflammation may induce hyperosmolarity, apoptosis, and a progressive damage of the epithelial cells. And so we learned also about how important it is to start from a good quality of TR film in order to have not a drop in our quality of TR film after the surgery, and maintaining the homeostasis of the ocular surface, because in case of bad TR film and not so good ocular surface, we may what can we do in these cases? We also during these days we learned how our therapies in different kind of dry eye disease. In case of hyposecretive dry eye, we can use, of course, artificial tears, steroids, cyclosporin ointments. But as I told you at the beginning, we take care of the clearance of dry eye. And in this case, I would like to maintain for a longer period the tear film that the patient is producing for a longer period on the corneal surface. And how can I do this? I can use Lux plug just to block the drainage, the clearance of the tear film. In very, very severe cases, I can also use scleral contact lenses, or I can use, of course, some instrumental therapies like the that has a generating effect on the lacrimal gland. And which kind of quantum flux we can use in order to take care of the clearance of the tear film. You can use a quantum flux in silicone that completely block the clearance of the tear film. We can use a collagen quantum plug to temporarily block the clearance, and we can use now canalicular gel that in a hyaluronic acid, cross-linked hyaluronic acid, to reduce the clearance without completely blocking it. And this is the Rexonary, and especially if we consider patient after a corneal surgery, after anterior surgery, second surgery, in these cases we need to restore the tear film, especially in the first months after the surgery. So we don't need to keep on using therapies for long period or long periods, for years, for instance, or for many months. And even, especially in these cases, I think that we can use quantum flux or temporarily have this effect, or canalicular gel that block, that reduce the clearance of the tear film for a certain period that is almost 6 months, in order to maintain for this period on the corneal surface the tear film and reduce the risk of having dry eye symptoms or dry eye signs in our surgical patients. And this is what I tried some months ago. This is a canalicular gel in a hyaluronic acid, a cross-linked hyaluronic acid that I insert in the inferior dorsolacrimal ducts, and it's very easy to use, and very effective. And now I want to show you 2 patients treated with FMLASIK, and before and after the insertion of this canalicular gel. You can see the erosions of the corneal surface that you can see also in the map on the right. And after 2 weeks of the usage of this canalicular gel, you can see completely restore the corneal surface, and you can see the map on the right part of this slide. And this is another patient. Before, you can see the staining of the corneal surface on the left, and after 2 weeks, the corneal surface is much more homogeneous. And so we can use this, I think that now we can use this canalicular gel also if we want to prevent the onset of this kind of problems or issues after our surgery, especially in a patient that have a major risk of having this kind of drop in the homeostasis of the ocular surface. And this is another possible application of this canalicular gel. And as well, I think that it's very important to use this kind of flux, this canalicular gel, especially in case of mixed dry eye, where we can have poor production, but also a bad quality of tear film with toxic substances inside, and where we don't want to completely block the clearance of the tear film, but we want only those talking about that, and I think this is an important issue. Sometimes this is debated. Some colleagues are for pro, some are against this kind of possible therapy. I think that it is very effective in selected cases, and I think that we try to block in specific cases, in case of hyposecretive dry eye, blocking completely for a certain period in the inferior duct, the drainage of the therapy may be effective in having good results and a good ocular surface, blocking completely, but in case of post-op patients, surgical patients, or in case of mixed dry eye, I prefer to use the canalicular gel because I don't want to completely block it, but I want only to regulate the clearance of it. And so I think that this is maybe something that we can use in order to treat our potential dry eye patient or post-op dry eye patient. Thank you very much.
perché vanno a migliorare la qualità del medico. Gli omega
tre si sostituiscono agli ipidi di membrana e con i loro doppi legami rendono la membrana molto più elastica e più fluido. Inoltre, grazie all'azione antinfiammatoria che abbiamo visto, riducono l'infiammazione del margine palpebrale e quindi vanno a ridurre la keratinizzazione dei doppi. Questo cosa porta? A un meno viscoso, molto più fluido, più facilmente esprimibile dalle ghiandole e quindi a una stabilizzazione quale achinale. Un'altra azione dall'IDH deriva anche la neuroprotettina di Lumo, che ha un'azione di protezione corneale perché va a stimolare i fattori di crescita nervosi e quindi gliali, promuove quindi la rigenerazione assionale soprattutto del riflesso subbatale e va a ridurre l'infiltrazione dei macrofagi creando un ambiente idoneo alla ricostituzione dei riflessi nervosi. Questo quindi sempre più studi stanno rinnovando il loro interesse nel ruolo degli acidi grassi omega 3 nel dry eye, soprattutto in sottogruppi di pazienti, in particolar modo quelli con disfunzione di ghiandole di Benone, andando un po' a confutare la conclusione a cui ha giunto il grande studio primo nel 2018-2020. Accanto ai macronutrienti hanno azione di cofattori enzimatici e di regolazione dei processi biologici anche vitamine e minerali. Tra questi il zinco, il rame e il selenio e noi sappiamo le vitamine come la vitamina A che è importante per la produzione delle mucine, il gruppo delle vitamine D che aumenta la densità corneale e ha un importante modulatore del neuropatico, la vitamina C che sappiamo essere un potente antiossidante sistemico, vitamine del gruppo D e del gruppo E che riducono le citokine infiammatorie e quindi permettono di avere un'azione antiossidante e antinfiammatoria. Un piccolo gruppo sono i polifenoli che hanno un ruolo di cofattori, quindi possono essere una regolazione sinergica con macronutrienti e micronutrienti che sono degli antiossidanti di origine dalle piante e sopprimono l'infiammazione e riducono lo stress ossidativo. Tra questi l'esveratrolo, la porcellina e la curcumina. Vi presento un caso clinico di una donna di 62 anni in buona salute, giunta alla nostra osservazione con diagnosi di occhio secco già trattata per altri colleghi con multiple terapie formulate artificiali, steroidi. Lamentava però uno scarso beneficio e presentava una sensazione di bruciore e elimina segni delle fatiche. Abbiamo usato un metallopropinate che era elevato. Abbiamo iniziato un trattamento con colline a base di acido ialuronico senza conservanti, uno steroide di superficie e iniziato una supplementazione orale con omega 3, associato a un gruppo vitaminico, minerali e un derivato dell'esveratrolo, associato a un'accurata igiene palpebrale. A un mese abbiamo rivalutato la signora e abbiamo già lamentava una minore sensazione di bruciore, l'iperemia si era ridotta, abbiamo avuto anche un aumento del mood e abbiamo proseguito la terapia con lacrime artificiali e supplementazione per altri 2 mesi, per dar modo ai liquidi di integrarsi appunto nelle membrane. A 3 mesi la sensazione di discomfort della signora era quasi completamente scomparsa. Quindi per concludere, la patologia dell'occhio secco è una patologia multifattoriale ed eterogenea, è caratterizzata da differenti meccanismi patogenetici e differenti fenotipi. Bisogna quindi andare ad attuare terapie topiche ma anche sistemiche, inclusa la supplementazione dietetica, e tra questi gli omega 3 sicuramente hanno un ruolo sempre più importante. Bisogna andare comunque a individuare i fenotipi dei pazienti e dei marcatori e andare a capire qual è il dosaggio ottimale e il metodo di somministrazione per andare a effettuare un trattamento personalizzato per ogni paziente con occhio secco.
There was a difference. No, a significant difference. That's why the new works try to understand if there is a difference between these different kind of pain or indifference at all to this origin from the refractive surgery, keratitis, petty keratitis. At the moment, there was a significant difference between the patients. The images was after 2 months. That was the complete treatment, which is very fast, very impressive. Again, this is the work of the doctor in Singapore. It's not my own experience, but it's very impressive.
Aspetta, ti levo pure qua.
L'ho preso a posto, non l'avevo visto, sì. Sono tantissimi, quindi questa sera
dove è andato Giovanni?
Sì, ho guardato un po' il panorama, via Menino, la piazza dei Vicini, e poi o Gave e via Gaia, o la strada Santa Lucia, San Giovanni, mare, ma riesco a trovare quella grazie sogno l'hanno chiamato Rado, Marco, Marta, bellissimo e grazie, arrivederci.
Ma non c'è un'immagine da sacco? No. Buonasera e grazie.
Però come facciamo la prova?
Esatto, non li faccio.
Good afternoon, everyone. Buonasera a tutti. So this is the trial workshop and roundtable from this definition. We have the engineer responsible for all the equipment here, Peter Baranovich, is from Czech Republic. And do you want to introduce something, Peter, please?
I can introduce and welcome everybody and also thank Giovanni and Luca for inviting us for again very successful meeting people who are passionate for dry. And I hope that we also can give you a little bit insight what we really enjoy to do. So I'm very happy to having us today, Luca Vigo, and don't forget Christina from Romania. So I'm very happy to cooperate with such nice people that will always bring very great insight for improving the people life, vision, comfort. So I will need to talk to Liliana to provide it to our workshop, which we prepared quite a nice program. Hopefully you enjoy. So
minutes, and then our presentations and round table discussion among us who are heavy users of the technology from Sesta division. So let's start with the patient journey. For example, in my clinic, I think that most of us maybe do the same, but we can do the eye fitness test from the tear check, which provides us the quality, the impact on the quality of life. When the patient has dry eyes, you have the questionnaire, the patient answer the questionnaire, and you have the final score, and you analyze the score and analyze the impact on the vision of the patient and impact on the quality of life of the patient. This is very subjective. The patient will answer according to their feelings, but it's very educative because as soon as the patient answers the question, he himself will learn about this impact on the quality of life. And so this would be the first exam that we perform into our patients. It will be the questionnaire, the eye fitness test. You can check on the...
If we can make this more interactive, I will advise you to scan the code and please do your test. And at the end of the workshop, we can count how many of you will fall in the mild, moderate, and severe subjective expectation of your trial. Please, there are plenty of languages, so whatever country you come from, please scan your code and fill in for us this questionnaire, and at the end we will see. You can tell us the score at the end of this questionnaire. We really think that the questionnaire is very important. I think that subjective feeling of the patient, and you have this experience also in your clinic. So we'll be very happy for your small participation.
It doesn't take too much time. It takes about 1 minute to answer the question. So it's a good start to a life patient journey in your clinic or hospital. Is there a volunteer for the eye fitness test or the patient? The volunteer, Thelma, can you come please? Thelma is also a Brazilian doctor from the northeast of Brazil. She specialized in glaucoma and she's very interested now in dry eyes. So she's studying hard and she built a beautiful dry eye center at her clinic in the northeast of Brazil. Peter will perform your test. Thelma. exams for the tear check. Then we will see Thelma's results, but she has a dry eye, she has been treating her eyes herself, but her break-up time in the right eye was about 6 seconds, and the left eye was about 8 seconds. So you can show it to your patient, and usually dry patients has less break-up time, less seconds than she did, but it's one of the most important exams that shows the stability of the tear film. So it's very important information in the analysis of tear film of our patients.
When you place this machine, there should be no airflow or current on top of it or around it, because this again will dry the patient's eye closely. Again, when you do the test, as you can see now, Peter is trying to take the image. He tries not to touch the inner part of the eye to avoid the exterior, and if the patient is wearing any makeup, you'll have to push the makeup in again cause another exterior. So this is the only part where it's interdependent, because he has to highlight the area that you can actually need to make sure that the image is taken well focused. If the patient is confident enough, will have a perfect image of the microphone.
Also, I think that it's very important to check the superior eye. In this case, we don't check the inferior eye, but as we heard this morning, it's very important also to check the superior eye in order to make a precise diagnosis and to treat the patient effectively.
So we just flip the eyelid in 2 or 3 seconds just to be able to make the mammography in the upper lid also. As you may notice that you want to check the eyelid superiorly also.
Settimana superiore mai, l'inferiore basta e avanza, è anche meno traumatica l'inferiore.
This gland will definitely not secrete anything from the chance. It's not. Even if you see the gland physically intact below.
Could we see a comparison score between the do you feel any eye worse than another one? The left one, yes. So we have this correlation between signs and symptoms here. Her abdominal glands on the left side are worse than the right side. This is the mammography. For me, the most important exam from the tear check, because it shows to the patient the abdominal glands. Usually, when you don't have this, you can tell your patient, oh, you have an abdominal gland dysfunction. But if you don't show images to your patient, it's very hard for them to understand their diseases and to compliance for the treatment. So that's why mammography is so important. So you see the morphology, the anatomy of the abdominal glands, its obstruction, the percentage of loss, and it's really a breakthrough in the propedeutic of the tear film, and and the leads and the two film and the leads. So we can examine very well and educate our patients about their diseases. More than a tool for diagnostic, it's a tool for education. So tear check is a tool for education that will promote adherence and compliance for the treatment, especially if you have IPL, for example. If you have technology for treatment, if you have a good diagnosis, it will be the first step to the treatment, to follow the treatment, the patient follow the treatment.
In fact, the patient will come and ask, did I improve? They ask me, what was my score before? I want to see my score now. Is it better or not? And very often you can see the improvement. I would like to highlight and emphasize on the morphology. So sometimes the mammography will tell you there is like 30% loss, 20% loss. But if you look at the morphology, this is crooked, this is thinned out, they don't orange to the point or the orifice. This is here in number, I can count the number, but the morphology plays a big role in understanding that the meibomian gland is actually dysfunctional now.
Also use the tear check for screening if you have a big hospital, if you work in a hospital with a big flow of patients, you can identify asymptomatic patients with the tear check if you use it for screening. You can also use for diagnostic, but you can use for all your patients for screening. Identify asymptomatic patients and then treat them prior to your ocular surgery, such as cataract surgery, refractive surgery, or blepharoplasty, for example.
We send your patients before your acne. We have agreed with the dermatologist that before they do your acne, you bring them in and check your meibomian gland. Because we have seen this line where the meibomian gland really becomes disturbed after taking Yes. We had some patients that were treated with that and they were about to us. Somehow we managed to do the mammography before, not knowing that they're going to have that treatment. And we did it in comparison, it was a huge difference. Because it does not become permanent. In my case, when I have a patient that has starting already on acne, I quickly bring her for annual. And this has preserved my body glands. They actually become acne that after the acne session I get much better. I don't have this much significant dry eyes as before.
What is important also to emphasize with our patients when we see the morphology of the meibomian glands. If it's a good one, you can emphasize with your patient, let's keep it that way. Let's continue making your treatments at home and at the office to preserve your meibomian glands. And on the other side, when you have important obstruction, for example, it's another way to talk to your patient. Please, let's keep going with your treatment, unless you will have more obstruction of the meibomian glands and more severity of your dry eye. Don't bet on that because the severity of dry eye affects too much the quality of life to the point that people can have suicidal ideas. So I have patients in my office with very severe dry eye with some suicidal ideas. So that's the importance to show the meibomian glands. If it's good or if it's bad, to give some orientations to our patients to keep going on a treatment all day long, every day, forever. That's part of our work to give this education to our patient in every visit. but keep educating in every visit. It's hard work, but it is our work to do that.
Actually, sympathizing with the patient, and this will make the patient feel much better, that you believe them. You believe what he's feeling. Once you show them that I believe how I'm doing that structure, give them the stability you have. Rapid breakout time is what explains what you are feeling, and this way the patient will trust you, and he will say that even if I might be exaggerating, but someone there is listening to me, and we are on the same page. This is very reassuring for the patient, by the way.
I agree completely with you because I think that high-tech diagnosis is important not only for having more patients, but for confidence, patient confidence, for patients, for prevention, for reassuring, of course, the patient in some cases, but showing also improvements over time in therapies. I think it's very important because you can show, you can give the patient something that he can help him also in following your therapy, in following your suggestions, and to prevent, as you told before, to prevent the onset of severe dry eye with severe symptoms.
All the exams from the tear check are very educative to our patients. The tear film stability evaluation, the breakup time. You can teach the patient how to blink and educate them about the blinking, the pause on the screen, and of course the logography, demodex if it's present. So you show to your patient that the eyelids are compromised with blepharitis, with demodex, and you make this commitment with your patient to treat demodex. You can show the demodex for them so they will have this impact on his mind to learn that they have something alive on the eyelashes, and so they commit more to the treatment that way. So it's very educative. You can use as diagnostic, you can make your treatment with IPL, you can follow up your patient after the treatment and repeat the tear check so you can show improvement in the evaluation of inflammation. You can show the improvement on the non-invasive breakup time. You can show improvement on the questionnaire and the score, so you can follow up your patient. So you can do as a screen, as a diagnostic, as a follow-up of your treatment. And it's very easy to perform the exams. It takes me around 6 to 7 minutes to perform all the exams from the tear check. Show the results, Peter, please. So let's see that one. So this is a color report from the tear check. It's very easy to show this resume for your patient because you show by colors. So when you are in the green, you have a normal result. When you are in the orange, you have a moderate, the yellow, mild, dry eye, and orange, moderate, and the red, the severe result of your test. So you can see the right eye, the left eye, and the patient can see with the colors how they are doing. So tell me you're not that good. So you have some exams on the red, few exams on the green. So let's check exam by exam. Peter, please show us. So you can see another report, exam by exam. First is the blinking rate. Up, please, up. So Thelma had all the blinks almost incomplete. Peter, see. So she had 3 blinks complete in the right eye and 5 blinks complete in the left eye. so that's a warning for you. So you have to blink completely. Exercise your blinking pause in the screen time. And you have some collarettes around the eyelashes in the demo exam. Can you see? Thelma, can you see the collarettes around the eyelashes? So we have a close of the eyelashes. So Thelma, you must clean better.
But in this station, we have to have more than 4 or 5 eyelashes with them. 2 or 3 are normal.
Yeah, okay. A little bit of some redness around the eye, the conjunctiva. It's not normal. This vessels around the conjunctiva. Of course, in moment you have a percentage of loss in the upper lid, and especially in the left eye. And you agree that your left eye, you have worsened symptoms in comparison to the right eye. So in the 3D, you have more percentage of loss of your abdominal glands, Thelma. But Thelma has IPL, so she has been treating herself every month almost. And so you have some abdominal gland dysfunction. You have rosacea. No.
But you can see the inferior ones are smudged. I mean, look to the morphology here of the inferior glands. The upper glands, although they are more prominent, some are wiped off, but the inferior ones are really need attention because they're just interlacing with each other. You don't see the distinct glands physically. I always tell my patients they have to look like a worm or like seeds, like lavender, on top of each other. And in this case, this is an early sign where you have to keep attention. Warm compresses might be IPL depleted, and probably you would also benefit from cyclosporin to reduce the inflammation and make sure that they remain intact.
Do you have moderate symptoms, right? Do you feel a lot your eyes?
Nowadays I'm asymptomatic.
Okay. Because you have been treating with IPL, right?
Right.
Okay. So in non-invasive breakup time, she has 6 seconds around the right eye and 8 seconds around the left eye. And the weather now is better than Brazil. She lives in a very windy city in the northeast by the ocean. And of course we live in the air conditioning, especially in the northeast of Brazil, which is very close to the equator. It's very hot. And
Did you try the in the past?
No.
No. Can I ask an unfair question? The main damage is the superior abdominal glands. So I'm using the area which is inferior. Yeah, I see.
No, she's not using IPL. She's using IPL.
Okay.
Yeah, another brand, yeah.
We should discuss about this.
Yeah.
Because we are treating the inferior.
Yeah. No, she knows the difference, but she has another equipment at her office.
So the unfair question is, do you think that using different
hygiene. I tell every month. LLT, low light level therapy. I do everything.
By the way, we don't need all of our own gastric functioning to do nothing. Really? Yeah. But at least the ones that are actually functioning. If I were you, I would add to my IPL expression.
Expression session. Yes, I do it every after section.
You do it?
Not me, of course.
Someone does it.
Yes.
We have a question from our audience.
A question for you. And do you find that the symptomatology of the patient is referable to one single point or to
lots of points, or there are some, I don't know, just E or mute or other characteristics, other points are much more parallel to symptomatology of the patient.
If I can answer this question, so to see this puzzle, looking on the color, without the numbers, you see already the outcome just to see the colors. No single measurement can tell you, yes, you have a disease, but it's a symptom that is related to something else. So questionnaire will be related to your subjective feeling. You know, that will tell you, yes, I feel the problem. The objective measurement will tell you, yes, I see the problem, but you can fake the measurement of breakup time to any machine. And that's a good example. If she brings properly, the outcome becomes quite good. But if she brings as she usually brings, outcomes are poor. So where these symptoms coming next, we see that because of that abortive drinking problem that you have because of that long time learning, you got a poor outcome. Then we see the vicious cycle of inflammation attract the parasites. That's the long-term story.
If I may add something, there is one characteristic of dry disease, and this is the disassociation between signs and symptoms. So they have lots of signs, no symptoms, and the reverse. So depends on the patient, depends on the sensibility of the cornea, depends on many things.
And the pain threshold. Some people that have to be amount of cortical sensation, this is normal for me, that's how it's supposed to be. And others complain from simple discomfort.
I think that this examination is very important, especially in case of pre-operative examination. I mean, in case of surgical patient surgery, because even in patients that are symptomatic, we need to show if there is something wrong with this patient. We need to explain why we want to treat this patient before collecting data for surgery. And we ask the patient to come back after 1, 2, 3 months after the therapies that we can promote. And I think that it is very, very important, especially in asymptomatic patients, of course.
I want to add something regarding her question. Most commonly, all these parameters are correlated one to another. So it's not that you can fix only one parameter that goes with the symptomatology. They are correlated and they are strict one after another. For example, if you're not linking well, then your film stability evaluation will be worse and your breakup time will be worse. Being the breakup time worse, your film stability worse, the mammography will get worse every month. So they go one with another, they're not independent. And if you screen like 1,000 patients, then you will see the correlation that when they're all bad, they go together. When they're all good, they go somehow in the same amount of disruption. So they are strictly correlated and you have to take them together. You cannot separate these parameters.
I was wondering if you have done any study on this.
Yes, my PhD degree is a study on this and it's comparing the parameters from the tear check on every patient and even the correlation
your treatment, and then do again the tear check, and do the comparison between the pre and post treatment, and you will see the improvement of the outward surface, the improvement of many parameters from the tear check. It's very nice to show it to the patients.
Please, in your practice, when you want to check with this device, you do it first before the exam is taken, because if the exam tests, we can test some aspects of error in the so you start by the test, and after you complete with players test to show the staining, so first the test.
First the test.
That's I need to be my practice on the own.
Yes, first the test, and to tell the truth, I add some other tests like the osmolarity evaluation and also the inflammatory test, looking for the MM9 biomarker. And so I do everything, and then I see the patient, I visit the patient, and also I check if there is staining or other issue like the examination.
If one time we have a patient that is painful at the problem, and the first thing we look after dry eye products, and I found that there is some problem with the movement, and once complete the exam, and I do the test, the radiography and this test, after I complete the exam. This is, the patient does know that he has a real disease.
I'm different from Luca. I work in a small clinic, so I don't get this big flow of patients, so I see every patient taking my time, almost 1 hour for a first visit of a dry patient. So I start with the basic. I start with a very long conversation and anamnesis. This is a video about my practice that you saw in my presentation. And I do the first steps of the basic propedeutic, shear test, breakup time, and the staining with the fluorescein and the cement. Then, by that, I do the diagnostic, and then I chat with the patient about the possibilities of treatment. So I start clinical treatment, I start changing habits, I start following up my patients, educating them in the first moment. And later, if in the first moment they agree to go for IPL, so I will perform the diagnostic with technology, which is the tear check, and then IPL. So in the first moment, if they don't agree, because they have to pay for that in Brazil, if they don't agree the first moment, so they will go home, they will start the therapy at home, they will start the lip hygiene, the warm compresses, the topical therapy, the anti-inflammatory therapy. Then they will come back to visit me again, we will chat again, follow up, it will improve. Now you want to go for technology, so that's the flow that works very well for me.
It's more convenient when we try first the basic treatments. And the basic I don't think it gets better, but yes, and we check it with another test, and you don't improve very, very well, and it's now the time to IPL or
it will depend very much on the severity of dry eye, because some patients have mild, moderate dry eye, they will look for me at the clinic, and they will try first the clinical treatment. But some patients come to me after seeing more than 10 ophthalmologists, after using all the drops, and they are very uncomfortable with a very severe impact on the quality of life. And this patient wants to do everything in the first moment. So I kind of feel the patient, and if the patient wants to do everything in the first moment, we are prepared to do everything in the first moment as well. So we have this agenda, we have this time if the patient wants to perform the first session, for example.
In my practice, it's a bit different because I look for the dry eyes to have successful outcome in my career, in my surgeries. I do plenty of cases of multiple premium lenses, but my standard is premium lens. Not because I'm doing clear lens extraction, no, but because I believe that premium lenses is the right of the patient to have clear vision. It is a luxury, it's a must. So in order to have a successful outcome, I make sure that I have a perfect surface. So part of my assessment for any cataract patient or any refractive patient has to have a clear assessment, even if the patient does not complain about dry eyes. Because to me, an ocular surface with rough surface, an imbalanced ocular surface means a bad outcome, and this will destroy my reputation and patients' expectations. So it's a must. I usually do at least 3 sessions of IPL before any cataract surgery I'm going for. Even if my patient has no complaint. If I have low breakout time, few SPKs in the center, here and there, an MGD that I'm not happy about, the expression is not the way I like it, I will just go ahead and do the IPL. Because this makes sure that it will balance for me. Proper biometry and proper outcomes.
Just to complete what I was saying, in my practice, the longest patient that I postponed for surgery due to dry eye, not severe, but sufficient enough not for the biometry to be correct, it was 1 year. So she came in August, let's say 2024, and we operated her on August 2025 after we were pleased enough with the results of the dry eye.
Question here, please.
Well, good afternoon. First of all, thank you so much for this workshop. We are ready to hear this. We are from Costa Rica and we have this equipment in our unit. And we've been seeing the results, and those are really, really good. And my question is, how long did you wait until you do the second mammography to compare? Because normally we do 6 months after the 4th session of EI. So I'm just wondering which is the best way to do it. Thank you.
Let's say the patient is complaining or not. Because sometimes I wait if the patient doesn't complain because he's happy, because has good results immediately after the treatment. I usually check the patient in 1 month after the end of the so, but I don't want to stress or to stress the patient showing all the results immediately because I ask the patient, I ask filling the questionnaire, of course, I ask the patient how is feeling, but I don't want to stress and to check the mammography and to go deep in this. Depending on what the patient is telling me in that moment.
Yeah, one tip for you. Maybe you repeat the check after treatment. You can repeat after 1 month, after the 4th session. 30 days after you can repeat, but maybe you will not see any change on the mammography. So don't be worried about that, okay? Because maybe you don't see the image, the difference at the image of the mammography, but you will see the difference in the subjective test, in the non-visible period of time, in the quality of life, in the symptoms of your patient. That's it. Don't stay attached to the mammography itself, okay? Stay attached to the improvement of the symptoms, etc. Thank you.
I agree. 3 months for severe dry eye, 6 months for moderate dry eye. And the first time you repeat, just focus on symptoms.
by chance, you see that the lithography in a patient with severe dry eye has increased, has improved after treatment, where the compliance of that specific patient will be 100%. So you will follow you completely. This is important.
As a patient, I would like to say that my quality of life was very, very, very bad. I used to feel my eyes every day, every moment, itching, burning a lot, burning a lot. I could even open my eyes during the morning. I used to do with my fingers to open them. And I was tired at the end of the day. I couldn't read properly at the end of the day because my vision wasn't good. And even though my essence is not so good, I can tell you that it was worst, much worse. Okay, my breakout time was immediately 1 second, 2 seconds. I could even do the test because I was tearing. So sometimes as I'm a doctor, when the patient wants to see the exam again, sometimes we don't see lots of improvement, but lots of improvement of the symptoms.
That's it, Daniela. I think so. But we improved a lot. Let me to move forward in this note because everybody is making it in a boring way. So let's go to the questions that we prepared for the presentation we see today, also from the comments of our experts. So, Liliana, what is the best patient for a treatment for you?
This is a slide from my presentation of the last year at Congress in Calabria. I asked Peter to put this to help me explain to you the main indications. When I first got the equipment 7 years ago, I was treating dry eye for 19 years before.
19?
So, 19 years before. So I've been studying dry eye for the past 25 years, since I left my residence program. And I was treating my patients only with clinical treatment, drops. And many times I feel frustrated because I couldn't improve. When I got the EI, it completely changed my results. And I saw patients improving in a very short period of time. So it really changed my life and the life of my patients when I first bought the IPL. And the first patients that I chose for treatment was MGD patients, blepharitis, rosacea, and Demodex patients because it was the main indications from the industry for us. So in the first moment, I would not treat my aqueous deficiency patients with Sjogren's, for example. But in many cases, I saw that my Sjogren's patients already had non-dominant dysfunction. And I started trying IRPL in my Sjogren's patients. And they started improving the symptoms. So it was another breakthrough for me because I kept trying patient by patient. And our Sjogren's disease is one of the most important groups that are treated in my clinic in Brazil. Later on, I started improving the quality of life for my glaucoma patients because they have a severe dry eye, secondary to non-dominant dysfunction. And they started improving the upper surface, they started applying again for the treatment for glaucoma and applying blindness that way. And so I give quality of life for my patients with glaucoma as well. Then I started applying IPL for my patients who were intolerant to the use of contact lenses. So they improved their ocular surface and they started using the contact lenses again, improving the quality of life. Imagine a person who has -6, it depends on the quality of life of a contact lens. And later, the pre and post-op of surgical patients, ocular surgeries, such as cataract, refractive surgeries, blepharoplasty, which is my area of acting as well, my area of specialty. And I started seeing the post-op of my colleagues or even my patients, and then I started treating previously, because all the knowledge that we were acquired in the ocular surface disease in the dry eye world, and I started preparing, I think it's the other question, but I started preparing my patients for surgery. And last but not least, neurodegenerative diseases like Parkinson and Alzheimer's. We have seen many patients, elderly patients with this kind of diseases. They don't blink well. Parkinson's, they don't blink well, and Alzheimer's, the same. So they develop severe MGD, and they develop keratitis, and sometimes they don't have a good mind to tell that to the relative, and they get with the eyes closed. They examine the eyes, and maybe you can treat with IPL as well to improve the ocular surface of these patients. So this is my main indications in my clinic that improve a lot the quality of life and the quality of the vision.
Thank you, Liliana. I think that would be the
chalation, also chalation, because Luca developed this protocol for chalation treatment, so it's been 2 or 3 years that I've been treating chalation patients also with the help of Luca, and we had some results, so we are avoiding surgeries on these patients by treating with IPL.
I would skip to the next questions, as everybody can add any comments to Luca, back to your question, as I remember that. How was the change of meeting this higher field technology, or the new adding the new, let's say, the protocols that you are now introducing, changing your professional life?
Okay, in full honesty, I started using this technology, 10 years ago, because not because I like it very much, dry eye disease, but because some of my patients complain for dry eye. So 10 years ago, there was the possibility to find the IPL technology. I knew laboratories in the United States, and I tried to find something similar in Europe. So I checked it through the web. I found that there was a company, this French company, there was a screen. I asked the screen to let me try the instrument in my clinic, and they sent me the instrument, trying it for 3 months. I had very good results, and since then I decided to keep it, and also I asked to some friends of mine that are distributors in Italy to distribute this kind of instrument in Italy. So this was almost 10 years ago. Since then, I treated a lot of patients, and also, so I took care also of dry eye disease. Of course, I tried to identify different kinds of dry disease using this technology. Of course, there was not tear check 10 years ago, but now I use also tear check. And since then, I also wanted to do something more, because I knew that there was the possibility to do something more. And this is the reason why I decided to apply this technology also to treat the chalazion. Chalazion is a typical, kind of meibomian dysfunction with obstructive lens, you can see here. And why not try to do something also in this case, just to avoid, like Liliana told us before, to avoid the surgery. And so this is what I tried. I asked the company to provide me with specific tools, like mask that could highlight especially the chalazion. And so I decided to use the same handpiece, I mean the same instrument, just to treat directly the chalazion of the upper or inferior eyelid. You can see here, I do the same, but the only thing that I add is the usage of this corneal shift, because I want to prevent, of course, the damage of the cornea, and especially when I treat the upper eyelid. And I put the gel, I add the chalazion using the specific plastic mask, and then I do usually I do 3 flashes on directly on the chalazion. I usually treat the chalazion, and also I treat the myometric extraction. So that means I do the standard protocol plus the chalazion protocol. The chalazion protocol is a little bit different from the standard protocol, because I ask the patient to come back to the clinic twice in the first week, twice in the second week, and so in 2 sessions, in 2 days, I do both, and in other 2 I do only the chalazion treatment. And then I ask the patient to come back once a week later, and another one at the end of the protocol, when I do the last standard session. But the results were quite good, and so I asked the company to provide me with a specific tool with a small tip, and I hope that in the future this will be available for everybody. The results are good, and you saw some pictures of my patients, especially I remember a young patient that was 13 years old with a big chalazion, and probably she was really afraid of doing surgery, especially her mom. And I had really very impressive results. So avoiding the surgery, and also to prevent the onset of the recurrences of other chalasia in the future, because I think that if we treat the chalazion, but also we do the standard protocol, we can prevent the recurrences. This is a good thing.
Any comments? Did you try the chalazion?
That if you treat surgically treat the chalazion with an active diffuse MGD, you may have 2-3 more chalazion.
Also, if you treat surgically, then we use the lens section in the lens, so they're not functioning anymore. But using this kind of protocols, you might reactivate or disobstruct the lens, so you're doing a viable and
time working in university setup, working in a huge private practice, then finally your small one. So how would you see your approach for the clinical scientific approach? How important is for the doctor in your setup? And after added mammography, you had a very nice presentation during the sessions. So what's the role for you playing specialist?
So as a beginning, from the beginning as a doctor, I did scientific research as a must because I had to, and after that, when I did not have to do it anymore, I continued because I wanted to. So besides the day-to-day practice in the clinic, we do research because we find we stay in front of questions that we don't have the answer to, so we have to find the answer, and we may talk with our colleagues all over the world. Some of them will come up with an answer that we can use, but sometimes we stop in front of the question that none of us has the answer, so then we start research. This is one of the reasons. And the second reason why we do research is because we want to have a better collaboration with the patient, and we have to know what we can guarantee to the patient, what can we say to the patients, especially chronic patients like dry eye patients. We need to counseling them very well. So in order to do that, we need to do research to know in what grade of severity, what will happen, what patient has to feel, or what can we tell to them, and how their future will be. So we do research just to improve the way we treat the patients, and because we have to. And the second question regarding the upper lid mammography, this research about the upper lid was born from another research. We did the first research to see how the IPL works, because we did not want to collaborate with a company that we did not know the results about. So before starting to work with Peter and his company, we tested the machine and the IPL result with the research. And during the research, we saw the differences between the lower lid mammography and the upper lid mammography, and it was something very constant from patient to patient. We saw the same things. So that's when we started to look at the higher approach and see that the fact that the morphological aspect of the upper lid mammography is very close to the severity of the disease. It has a direct relation with the debut, with the function that the patient feels, and if the score of the severity is higher, then the results will be much more modest. So that's what helped us to do counseling with the patients, because we were doing the mammography and we knew exactly what we can say or not to say to the patients. So that's what helped us a lot.
Any comments from others how you could feel the research, especially Paolo, you as an expert in San Paulo University Hospital?
I think that research is a key factor to obtain a serious answer for our patients. My experience with IRPL was started a few years ago, 3 years ago, and I was quite skeptical because I'm skeptical of definition. But now I can summarize that patients with meibomian gland dysfunction, this treatment is my first line, as I said in my previous talk today. And NGD in Milan is, I would say, 80% of the population. So, yeah, I don't want to repeat what I showed you before, so you can skip the one. Yeah, in the end, if you compare the treatment with doxycycline alone, or IRPL alone, or IRPL plus doxycycline, it is clear that the use of thermal treatment is effective. My publication was patients are in the inferior part, and you go on the temporal side, and this to me was not a satisfactory answer to the question, how can you treat the superior eye? Still, the experience is exactly the opposite. In the end, also patients with damage to the superior meibomian glands have amazing results with IRPL. And the second question was about how is the Schirmer test in these patients? So, go on, please. We review the data of the data set I showed before, and we find out that 22% of the population with MGD has abnormal Schirmer test. And once again, I was quite skeptical on the potentiality of IRPL, and I had to change my mind because, as you can see here, the effect is nearly double on Schirmer test. Here, we stopped at 6 months. After 6 months, we lose effect. So, these confirm the fact that after 6 months, in a larger percentage of patients, it is recommendable to perform a booster. Keep in mind that there are no responses. So 25% of the population with low secretion will continue to have low secretion regardless of IRPL or homocysteine.
But I think that it's very, very important to say that there is this undirected effect in stimulating also the lacrimal because this is something that we can consider. And I think that really.
So I have sugar patients improve after IRPL because they improve the bone length, they improve the non-phasic critical time, but they also improve the microbiome regulation.
That's interesting, outcome finally that Paolo confirmed by his very focused clinical study. That's what we did in this huge data collection that you can chance to participate here with the same outcome. Even we were not looking for that proper aspect of the data collection, we accomplished the same outcome as Paolo.
Luca, adesso la faccio mettere su. Metti quella foto là, grazie.
One is missing, Donald Trump.
Aspetta, dammi il telefono.
Any questions? Any questions? Any questions?
At the beginning, we've been told that we need to repeat one session annually, like to maintain. So, did you do it in 6 months? It is only one. That's right.
Yes, it's only one. See, I don't know, personally, I don't know how to continue the story. So, what will, basically, in my previous talk, I showed you that 80% of the population will maintain the advantage for 1 year. So, perhaps, there's no need to treat them so frequently.
Or if they keep the symptoms or something, we can do it at 6 months and then regularly once a year.
Maybe the patient will come. So we don't keep checking on your patients, but the majority of my protocols are 4 sessions and then 1 maintenance session per 6 months. Okay, every single one. Just one. We are doing good.
Thank you for this gift. I like it.
Thank you very much for